Dr. Steve Duffin is a general dentist who has practiced for over 30 years, mostly in public health settings. He has a degree in microbiology from UCLA and dental degree from Emory University. From 1994 until 2006, he was the dental director of the largest Medicaid dental plan in Oregon, serving over 200,000 members. Recently, his interests have turned to basic caryology research and the application of minimally invasive approaches to caries management. Moffett Burgess is a dentist and the dental director for Public Health Seattle and King County. The health department operates 5 FQHC community clinics, 2 county jail clinics, a mobile homeless dental program, and a mobile school-based outreach program. She has a degree in research science from the University of Washington School of Public Health and Community Medicine. Her public health focus centers on approaches to management of oral health in populations with very high burden of disease. Please welcome Dr. Steve Duffin.
Thank you very much. It's a pleasure to be here at NNOHA with all of you and share this message. We're going to try and get through all of our material and leave enough time for Q&A at the end. I'm sure there will be some. I noticed that lunch is right afterwards, so we'll hang around as long as necessary. So again, a little about me. You've heard the basic story. I've been doing this for 30 years, mostly in public health setting. I've been a chairside dentist. I've been dental director of a large plan. I've seen this problem from many different perspectives. In 2005, I went back into private practice to try and look at the problem of increasing caries rates because I wasn't seeing solutions at the organizational level and at the policy-making level. Today, my clinic in Wilsonville, Oregon, sees about 75 children a week. We have a lot of kids coming and going. My mix is about 60% capitation and 40% fee-for-service, so we have a different mix of patients in our practice. We also provide care for seniors in long-term care centers. Root caries is beginning to be another type of epidemic that we're dealing with. And so one of my entities serves that population. And my entire career I've been interested in special needs patients. And so I've been involved with hospital dentistry and outreach dentistry and special care centers. So disclosures, I'm the owner of Shoreview Dental LLC, which is a private practice in Wilsonville, Oregon. Dental director for Oral Health Outreach, which is an entity that partners with hygienists providing prevention services in long-term care centers and with collaborating dentists. I'm a consultant with Advantage Dental, which is a large Medicaid provider in Oregon that embraces this medical management approach to care. And I'm on the Quest panel of experts for new products. And I'm involved with research and development on a single unit dose fluoride, silver nitrate fluoride varnish system. I'm sorry that list keeps getting longer. I always wanted just to be nothing, but my life is getting more complicated, and I do want to be honest with you. So to start off, we have built an electronic open source library, mmclibrary.com. And it is at this site where I've tried to collect all of the literature that I believe is applicable to this approach to care. And there's a great deal of literature that you can't find if you Google it because it has never been digitized. The early literature of the dental profession prior to 1950, when silver nitrate was used widely, has never found its way onto PubMed. So this is an actual image of the G.V. Black archive at Northwestern University, where I sat for 2 days, went through his handwritten lecture notes, and really got to know G.V. Black. I visited the archives at Northwestern University, the ADA Library, Ann Arbor, Michigan, Boston, the Centers for Disease Control. I've gone all over the country finding the literature that isn't digitally available, and we've we placed it at this particular library. So I encourage you to visit our library. This presentation is being recorded today, and this presentation will be posted on the library for anyone to see in the future. I also want to give special thanks to the California Dental Association, who published this paper on the medical management of caries in exactly 1 year ago, November issue of their journal last year. This is the first paper on the clinical use of silver nitrate in caries management in 50 years. So if you talk about there's no literature, there's no evidence, there's no I know, okay? I'd really like to know why we forgot about this stuff. It's important. And here's what I hope is opening the door to this important subject. This is also available on our electronic library. So a little bit more about my story and how I found my way here. In 1994, I became involved with what became the Oregon Health Plan, which is the first real statewide experiment with the federal Medicaid program. And Oregon got a waiver to manage their Medicaid program. And so on day one, I got involved with that. I was very excited about it. And I stayed there for more than 10 years. And I became frustrated because as we saw the Surgeon General's report in the year 2000, things seemed to be getting better, but worse, a lot worse for some people, and especially Medicaid children. I kept seeing caries rates going up, and I was involved with fluoride varnish programs and sealant programs and everything that we possibly could do on an organizational level, a policy-making level, and I wasn't seeing the results that I was expecting. One day in 2005, I was in my car driving around looking for a dentist that had contacted me who wanted to become a Medicaid provider. That's a very unusual scenario. So I was actually lost driving around this neighborhood, and I ran across this empty building. And something inspired me to stop my car and walk in the building. And I did. And the scenario was in this zip code, 97303, in 2005 in Oregon. There were almost 10,000 Medicaid-eligible children and no providers. 0 providers. So you can imagine what the pent-up demand and the need was there. So that was what I was trying to solve. When I walked in the empty building, I looked out the window and that's what I saw. Something inspired me to become the dentist I was looking for. And so within a couple of days, I fired myself, I rented the building, and I decided to go back into the trenches and try to figure out what we could do differently about treating this disease. So within a few months, we had remodeled the office and brought along some of my key employees, and away we went. What do you think it was like the first day? When you open a dental office in the middle of a zip code with 10,000 Medicaid kids with no access to care. It was an avalanche. The phone rang off the hook, non-stop, all day long. We had people waiting in line at the front door for the first several months that we were open, okay? It was a nightmare, but I can tell you that I did it on purpose because I want to understand this problem better. I sort of threw myself in front of the train. So we had emergency calls at night, on weekends. We had, it took us a while to absorb this pent-up demand. I had 3 and 4 months of hospital cases waiting. Children with 8, 10, 12, 15 cavities waiting to go to the OR to be treated. And fortunately, I'm fluent in Spanish, and a lot of my Medicaid patients are Spanish-speaking, so that helped. And starting in 2005, I believed that I did all the right things. Isn't motivational interviewing great? Yes, I went to the motivational interviewing seminar. I didn't just listen to the blip on the internet. I learned motivational interviewing. Okay, we always emphasize oral hygiene for every patient who walks through the door. We emphasize all the right things, talking about dietary counseling, the role of sugar in this disease process. Every single patient that comes through our doors gets these standard interventions. We enhanced the recall schedules. When I opened this practice, I wasn't really happy with the idea that one size fits all. So 2 cleanings and exams a year doesn't work for every child, especially the child that has 12 cavities and a family with rampant disease. So I set up the business model of my practice so that I could circumvent those rules, and if I thought somebody needed to come in every month, I could do that. So we tried to tailor the treatment that we're providing to meet the needs of the individual patients. Fluoride varnish, how about more fluoride varnish? We were throwing so much fluoride varnish at the community, I thought we were going to sink. Sealants, more sealants, tried betadine, CHS rinse. You know, coming from a microbiology background, I knew that what was missing here really is an antimicrobial component. We have a communicable bacterial disease, and we don't have an effective antimicrobial. Started asking questions. Went to Head Start, went to WIC. School screenings, okay? These are the things that we all do, right? And they're the right things to do. I didn't mention Canberra, I'm going to come back to that. Those are the right things to do. But in spite of doing all those things intensively for over 1 year, what happened is that the most at-risk children didn't get better, okay? I still had this happening, so it was very frustrating. If you look carefully at this slide, you'll notice that this child's been to the dentist before. In fact, this was a case that was a turning point for me, because this child had been treated in the hospital 18 months before we were taking the child to the hospital to retreat them, okay? Why on earth would a child need to have a repeat hospital dental case? When I was a dental director in Oregon, I would see these repeat dental cases and wonder, why are we doing this? These are very expensive. We now know that it puts the child at risk for general anesthesia that we haven't considered. This is just the wrong thing to do. So this really woke me up, and I started to look for other answers. So to summarize, in 2005, my practice faced an avalanche of disease in Medicaid children. We were doing all the things that I thought were right. We weren't seeing the kind of results that I would like to see. So I started to look for other answers. I started to look at the historical literature of dentistry, okay? I went to dental school in the 70s. We didn't study a whole lot about what was going on in dentistry in 1890. So I went back to 1890, W.D. Miller, G.B. Black. What were those guys doing, okay? And I had a plan to incrementally pursue the literature year by year. I think I own every text ever published with a topic karyology on it. So I really pursued the literature. What I found, and here's an image of W.D. Miller, who's really the first father of scientific dentistry. He's an American dentist practicing in Berlin in the 1880s. He wrote a monumental textbook called The Microorganisms of the Human Mouth, in which he proved for the first time that cavities are bacterial infections. W.D. Miller began using antimicrobial agents to affect the outcome of caries back then, in 1890. I went on to G.B. Black, and yes, I did have textbooks of G.B. Black when I was in dental school that taught me exactly how to cut little holes in teeth and to do fillings. I had no idea that G.B. Black was an oral microbiologist, and that he wrote an immense volume 1, The Pathologies of the Hard Tissues of the Mouth, in 1908, in which he describes karyology in great detail and describes how to use silver nitrate as an antimicrobial agent to halt the progression of caries. So this central message that I'm sharing with you isn't my message, it is G.B. Black's message. It's there for you to revisit my library. Percy Howe comes along in 1917. Percy Howe is the first clinical director for the Forsyth Institute, to which this day is the leading research dental center in the world. Percy Howe advocated the use of silver nitrate extensively during his tenure at the Forsyth Institute and when he was the president of the ADA in 1928 and 1929. So as I looked at this literature, what did I find that these people had in common? All three of who I call the founding fathers of the dental profession, all three used silver nitrate to treat caries. If we go back and look at accepted dental, okay, in 1934 it was called accepted dental remedies. Today we call it accepted dental therapeutics, all right, our standard Bible. Guess what's listed in there in 1934? Silver nitrate, okay? This was extensively used for a period of time, and then it dropped off the radar screen. That surprised me. And so I began to wonder, maybe is this something that we can revisit? What do we use today? Fluoride, right? And fluoride's great. I have nothing negative to say about fluoride, all right? But more fluoride, in my experience, wasn't solving the problem. This month, the EDA published a systematic review on the efficacy of topical fluoride agents for caries prevention. In 2011, the ADA published a systematic review on the non-fluoride topical agents. Okay, I encourage you to read those. They're available in our library. To summarize them, the findings are not as dramatic as we would hope they were. Okay? These things work, but they don't work for everyone, and they certainly don't work in really high-risk populations. So what we're introducing today is a new concept. It's really an old concept being brought back. Okay, the concept is to use an antimicrobial agent, in this case silver nitrate, with fluoride varnish. So I began doing this approximately in 2006. And I also studied the use of silver fluoride overseas. Silver fluoride is not available in the United States. There's some efforts to bring it here. It's under FDA consideration, but it is not here. Silver fluoride was developed from the historical use of silver nitrate. So we began looking at these, and this protocol involves both of these agents. So we might ask, first of all, can we legally order silver nitrate in America? I get asked that question every day. Yes. Henry Schein. I mean, I was amazed when I opened up my Henry Schein catalog, and lo and behold, there was silver nitrate, 25%. It's been there for decades. Okay? Where's it manufactured? Is this some illegal product made in a third world country? No. Gordon Laboratories is an FDA-registered manufacturer in Philadelphia, Pennsylvania. You can call them up and talk to them. Yes, that bottle looks like it was manufactured in 1860. I've been trying to talk them into it. But it's available in the United States. It's available from Henry Schein. So why do we need this? So this might be a little unsettling. Why do we need something new? Why do we need something old like silver nitrate? Okay. Well, I like to say the usual stuff isn't working. How do we know that? Here's the cover of the New York Times, March 6, 2012, 1 year ago. Cover of the New York Times. Okay. Preschoolers in surgery for a mouthful of cavities. Cavities are increasing dramatically in certain populations, low-income populations in America, and more children are going to the OR to receive care. We know that's happening. All kinds of press about the increasing problems of dental caries in this country today. You can use lots of examples. So we need a different solution. I'd like to emphasize that my overall approach in managing caries in children involves primary prevention. I don't want children to get cavities. I don't want them to have cavitated lesions. Far too many do. So if we can prevent this disease, we should do that. We should all do it. So in our practice, every child gets primary counseling. They get preventive measures. They get fluoride varnish, etc. We promote the use of fluoridated toothpaste. All patients are assessed for caries risk using cambermetrics, okay? But what's difficult is when 75% of your new patients come in with active decay, how much value is a caries risk assessment? Now, I don't want to criticize Canberra or caries risk assessment. I value it greatly, but the world that I live in, okay, we're in the middle of a war. We're not in the negotiating how to prevent the war. So, when primary prevention fails, what do? Right now, we don't have a lot of options, and we have thought that we take the child to the hospital, fix all their teeth, and send them home again. I'm here to tell you it doesn't work. That simply doesn't work. So, with 75% of my kids coming in with active cavitated lesions, you know, the usual patterns that we're seeing on very young children under age 2 is the classic ECC anterior decay. In the older children, and unfortunately a lot of kids don't come to the dentist until they're 3 or 4, 5, they've got decay in all their teeth. Posterior, anterior, and often don't come in until something hurts. So prior to 2006, basically I would triage those patients. Do you have pain? Do you have a draining fistula? Disease control, let's get the teeth out that are hopeless. Let's try and manage the active disease, prevention interventions, get you into a restorative program. That was my approach. And this is basically what we see every day. So I'm going to go through this alternative therapy. What is it like? How do we do it, etc. So this is the silver nitrate plus fluoride varnish setup. If you look at the tray, first and foremost, you see a unit dose fluoride varnish, then you see a Duffin dish. The Duffin dish has 1 drop of silver nitrate. I'll show you another slide in a little bit, but 1 drop of silver nitrate can be applied to a lesion that's been carefully dried, air dried, and it will treat basically an entire mouth of a child with 6, 7, 8 cavities for a cost of about 12 cents to add the silver nitrate component. At the MMC library, we have an entire 10-minute video that shows how to set up the tray, how to transfer the silver nitrate, etc. That's available to you. I want to run this quick little video. Shows actually intraorally what's going on. So these teeth have received 1 treatment before, so you can see the darkness. Okay, that shows a cavity that has had 1 treatment of silver nitrate. This is a child with decay in 4 quadrants. They're receiving their 2nd treatment.
Open, can you try to keep
that? And notice on this last tooth,
open one
you
more.
now have some saliva contamination on that tooth. So before placing silver nitrate, we go in and dry the tooth.
Yeah. Good job.
Saliva is an impenetrable barrier to silver ion. Okay? You absolutely have to have this tooth dried. So the technique is very, very important. How long would it have taken to treat the lesions in all 4 quadrants of that child if the child would cooperate for care versus this 2 or 3 times? It's amazing. So I want to emphasize that I developed this protocol empirically. I did it, I saw the results, I fine-tuned it over time. We were looking clinically, we're also looking in the laboratory at how effective these antimicrobial agents were. Okay, and guess what? Sometimes it didn't work. In fact, early on when I had so much enthusiasm for what I was seeing in terms of active caries going to arrested caries, I was astonished by a few failures. And I looked at those failures carefully, I sectioned the teeth, I tried to figure out what was going on, and I fine-tuned the protocol. And I realized that 1 application probably isn't going to work on every lesion, especially deep lesions or interproximal lesions. So I added multiple applications. Saliva contamination became a problem, so I added the fluoride varnish. I'm happy to add fluoride, but the varnish is really to hold the silver ion in the lesion. So over time, this technique was fine-tuned. And over about 6 months, all of the failures stopped. They didn't, diminish. They stopped when we fine-tuned this protocol. This shows really quickly, step by step, setting up the silver nitrate fluoride varnish. The second slide shows the movement of the silver nitrate from the old school bottle from Gordon Laboratories into 1 drop. We recommend that you only have 1 drop of silver nitrate in the operatory with the child. We have spilled a bottle of silver nitrate on our counters. We have a nice image of my hands that are black. I had to wear 3 gloves. Okay, there are a lot of ways to make this not work. So we've figured out how to ensure that it does by controlling it. Okay. We have this last slide showing treatment of silver nitrate with root caries. This is just a miracle for root caries, for which there is very little restorative options for many of our seniors. Okay? So, as we now know, when a lesion is treated with silver nitrate, it turns dark. Okay? So a dark lesion turns black. I wish it turned white, okay, but it doesn't. So we just tell the patients and the parents that up front. This is a sign that the infection is dead or gone. All right, expect it to turn black. Now, if we're not happy with what it looks like, we can restore it. This doesn't remove the restoration step. This is a disinfection step. So what we found over time is that when we decided to restore these teeth, we didn't need local anesthetic. That's astonishing. Why would that happen? Well, it would happen because you've got a significant amount of secondary dentin once this infection is gone. Okay? So we can restore these teeth. For large cavitations in the posterior regions, these teeth are basically space maintainers. Okay? And in the old days, I would be putting pulps of stainless steel crowns on all those teeth. Absolutely, I've done that for decades, okay? If you showed me this slide 10 years ago, I'd probably pass out on the floor, right? Today, I'm telling you, arrest with silver nitrate, put a protective glass ionomer restoration in there to get rid of the food traps, etc., and you're done. And I've seen teeth remain stable like this for years. Remember, we started doing this in 2006. Long time. Here's another example of occlusal decay. Arrest with silver nitrate, place glass ionomer triage right on top of it. Does that sound heretical or what? Yeah, good. Okay. This, in my view, is the best quality dentistry we can do. Okay? We are disinfecting the tooth, we are treating the tooth biologically, and then protecting it with a fluoride-releasing agent. So once again, this is technique sensitive. Don't even think about doing this unless you get your head around how to do it right. Absolutely. And we're not here to teach you how to do that today, just to introduce the idea. Okay? I've had the great good fortune to be up to Seattle to visit Dr. Burgess working in her clinic, seeing her doing this better than I do it. And she gets the results she gets because she does it correctly. It's really a remarkable story, and I'm anxious to turn the podium over to her. So, you know, my use of silver nitrate, number one, it allows me to begin treatment immediately. What's the standard way to approach new patient? New patient, x-rays, exam, prophy, needs fillings, make appointments. Okay? How often does a patient get treatment on the first day? Well, we realize that we can begin treatment immediately. So for every patient that comes into our office, during the exam, if we see caries, we open a drawer, we get out the silver nitrate, and we begin treatment right now. There's no lag time. Very little local anesthesia. When we do a cosmetic or a functional restoration, we use much less local anesthetic. Kids and parents don't mind that, okay? I saw a dramatic reduction in the number of children that were going to the hospital, and surprisingly, a reduction in the number of new caries in the treated cohort. So when we started looking at the population of patients that were treated, does it work? How long do the caries remain arrested? Do they abscess, etc.? We found that very few of these children get cavities in the future. So my overall impression is one treatment probably doesn't work, 2 to 4 works quite well. Okay? It seems to be independent of behavior and diet. I mean, we always emphasize brushing and flossing, oral hygiene, reducing the amount of sugar. We need to do that. However, we have a significant number of children who got all of their lesions arrested, okay? Came back 2 years later, and I find out that they haven't changed their behaviors at all. All those lesions remained arrested. That's amazing. Okay, this graph shows what happened to our hospital cases. We've done 1 hospital case in the past 4 years. 1. As a consultant with Advantage Dental that provides care for 200,000 Medicaid patients in Oregon, during 2011 we did sort of an intensive training for about 100 dentists in Oregon on silver nitrate. Okay, so it's been implemented. This data was shared with the legislature in Oregon about 3 months ago, and I have permission to share it with you. The incidence of OR hospital dental cases between 2011 and 2012 was cut in half. Okay? We don't know of any other reason other than this. It needs to be duplicated, but it's dramatic. So it happens in the clinic. Can it happen in the community? It seems that it can. Another important thing is we can see more people. Instead of a 45-minute appointment for a pulpotomy, a stainless steel crown, and maybe a couple of sealants, I can get 5 kids through, 5, 6 kids. Okay, a silver nitrate plus fluoride varnish appointment takes less than 5 minutes. Increase the access to care. Quick little story, Italia. Italia is the most medically fragile child patient I've ever treated. She came in, she had a spinal cord injury at birth. She's in a wheelchair with a respirator. Never been to the dentist before. So she's smiling for the picture. Believe me, she wasn't smiling when I came in the room. Okay? And guess what? She had occlusal decay in all of her posterior teeth. No anterior teeth. So 7 years ago, I would be thinking she's going to the hospital. Okay? And I actually called the anesthesiologist where I did my outpatient surgeries and discussed her medical situation. Guess what the answer was? No way. We would never attempt to do a general anesthesia on this child. Fortunately, we were using silver nitrate at the time. So what did we do? This is what we did. Fortunately, we were using silver nitrate at the time. So
What's the medicine? It's okay, sweetie. It's okay. It's okay, honey. It's okay.
So that was treating 1 lesion, silver nitrate, fluoride varnish. We won't spend too much time with this. But we were able to treat her. How else would you treat her? Okay, treat those lesions. Now, I had the good fortune to be visiting my clinic about 4 months ago when Natalia came back. She vanished for years. We really didn't know what had happened to her. And she came back into the practice, and I saw her and her mother, and I'm happy to say that she now is out of the wheelchair. The trach is gone, okay? No longer respirator dependent, and she is getting better. Most importantly, she has about 7 little black spots in her mouth that are arrested. She has no new caries. She's a happy camper, so I just had to ask Mom what Mom thought about this mode of care.
I'm so happy to see Italia today looking so good and so healthy. We've been able to treat her cavities with medicine for the past 3 years. No needles, no drills. Has that worked out pretty good?
Yeah.
She's a lot happier coming to the dentist now. Yes, I remember that. This is a happy visit. Do you think this would work for other children?
In fact, this works for all children. Okay? If you can do this for one person, you can do this for every person. And that's what motivates me to continue to share this message. And everything that we've been through to develop this technology comes back to Italia. And she inspires me, and I'm so happy that we were able to do that. We can do this for many other people. So what concern should we have when we think about using silver nitrate as an adjunct to our other therapies? Well, parental concern, especially about the discoloration. What I found is that when we confront that right at the very beginning and say we have some medicine which will stop the infection in the tooth and it will turn dark. In fact, when it turns dark, we'll know that it's effective. When you message it in that way, it's not a problem. Okay? And if the dark coloration is a problem, we can always put a white filling in there. Does it really work? Well, I have almost 7 years data. We've treated thousands of patients. We'll come to the data collection in a minute. We have other dentists, including Dr. Burgess, who is doing this, collecting data. We're building an enormous amount of data that shows us that this does work. Okay? What about the supportive literature? Well, you can go to MMC Library. It's kind of fun to read that old stuff. Okay? And you have one recent paper, and I'm looking to all of you to write the papers that we're going to see in the years to come. What will my colleagues think? You're doing something different. Okay? Yeah, thank goodness. It works. It really works. Okay, but you've got to have data to show that it works to convince them. How will I get trained? Well, we'll come back to that. And then how will I measure my outcomes? These are important questions. So, yes, I do have data, but these are the caveats. Okay? These results are from my practice. My patients that I treated, I scored the baselines. I had my assistant extract the data out of the charts and compile a monster spreadsheet that allowed us to look at how many lesions did the patients have, how many treatments did they get, and when were we finished with their care. Okay. We did some randomization. This is a snapshot of the spreadsheet. It showed that these caries, when they're arrested, remained arrested for long periods of time, up to 4 years. Okay? I was concerned how many of these teeth abscessed. Okay? Of 106 children that we selected out of our treatment cohort to collect data on, okay? 567 lesions were tracked for up to 4 years. Only 7 abscessed. And we don't really know why they abscessed either. Okay? Only 7. So the rate of success in achieving arrest was 98%. You know, anything in dentistry that even approaches that kind of success rate. It's amazing. It amazed me. It really blew me away. Today we're using a more sophisticated data management system. This was developed by Dee Robertson. He's an retired IHS pediatrician who has developed an access database to track the treatments and outcomes. And I do have some silver nitrate outcomes. You know, at 6 months we're showing 97% success in arresting caries in children. And at 1 year we're showing 90%. Now, it probably is decreased because we put some fillings in there, okay? Even though the tooth was arrested. So a tool exists for looking at this data in great detail. Dee Robertson is the president of Quest, which is an organization that has put on 4 symposium on early childhood caries in Native American populations. I was invited to speak in 2012 at one of these, and I'm going to extract a statement that Dee made from 2010. These are all on our library. Okay? First of all, the populations in America with the worst caries rates are whom? Our Native American populations. Okay? It's astonishing the rate of disease that goes on in those tribal populations. And they are the population that we owe the most to get an answer. So Dee challenged us, you know, why are we not getting more progress? We have the public health infrastructure, okay? We have enormous resources being directed through IHS. What we're missing is the technology. Now that was and talked with him about the technology, and I emphasized that this is my opinion. That's all it is. But my opinion is that the missing technology that Dee talks about in that symposium is right here. It's silver nitrate plus fluoride varnish combination therapy. If this works 98%, is there anything else we should be doing? Okay, who will this affect the most? Our Medicaid kids, our tribal populations, our seniors. We've treated thousands of patients with this protocol. Not a few hundred, thousands. No adverse outcomes. No adverse outcomes, not one. Okay, if you want to learn more about this, come see me. There's my email address. Contact me. Be happy to talk with you. We are looking for a few good collaborators. We're looking for a few good sites that will do what Dr. Burgess is doing. Okay? And it involves a dedication to the protocol. It involves support from admin to collect data. Okay? If we can get a number of sites that are getting the same results that she and I are reporting, we can change the future of this profession. I'm certain about that. Thank you. Dr. Burgess.
I've been told I have to stay at the podium, which is hard for me. I'm gonna hang on to it, maybe. So thanks for the kind words. And really, this is a really meaningful topic for me, and it's a genuine honor to have an audience for NNOHA to bring us together as safety net providers to really talk about the big problem that's out there. We all see it. And I think we're all struggling with how do we make a big difference. We're doing what we can. And yeah, it's just really exciting to be able to say something different than what I've been trying to do for 10 years. So I really appreciate this opportunity. It feels very special to me. I'm a dentist in Seattle. We have 5 community clinics. I'm the dental director. So 5 clinics, 2 county jails, a mobile homeless clinic, and a school-based prevention team. So, you know, I'm very similar to a lot of the folks in the audience, a dental director dealing with a high-needs population. Before I became a dentist, I went to grad school in research and got a PhD from UW. And, you know, to some extent, it's nice to have the letters in my name, but to some extent it has helped me be really interested in the data and be willing to put some work into collecting data. I don't have any disclosures. I'm a dentist. I'm trying to figure out how to treat patients in a way that works for them. If somebody wants to pay me to do this, that'd be good. So our clinics serve primarily low-income pregnant women, adult homeless, and kids. We have about, for kids, about 25,000 visits overall, a little over 40,000 visits. We're FQHCs like you are. Most patients are either Medicaid covered or uninsured. So I think in this group, we know that population. We are sort of uniquely good at figuring out how to treat them. I think we are also uniquely good at trying to message prevention. But the message of a topical antibiotic that can be used to kill cavities is something that I think will resonate well with the high needs population, and it would be harder to introduce it, I think, into the private practice world where there's a less of a burden, possibly, of disease. So the foundation of all dental practices with high-risk folks is counseling on diet and hygiene, regular use of fluoride, sealants on permanent first molars. I'm also, similar to Steve's statement, I was trying to do all the right things, including convincing patients to change mostly their diet is what I've been focused on. I'm mostly worried that is is something that's harder to change than brushing, and is not budging very much. When our kids come to the clinic, on the initial visit, on recalls, they have a lot of cavities, a lot of babies with cavities, a lot of kids. By the time you take wing x-rays, you're cringing. You already know, that 4-year-old's probably got interproximal decay, even if you don't see it in their mouth. So it's the high-risk kids, the normal preventative efforts that we've been working on. It's not reaching a lot. It's not having a huge effect over the 10 years that I've been trying to do that. I haven't been successful, and it's pretty frustrating. The usual pattern of decay I see is, for babies, it's the anteriors, and then as they get older, they get interproximals, first occlusals, then interproximals, and you can end up treating a kid 3 times during their baby teeth life cycle. It's really crazy. For primary anteriors, those, I don't think my dentists are here, but if they were, they would tell you I'm always trying to come up with something that actually works for anterior baby teeth. How do you do good fillings on baby teeth? My fillings fail at a rate that I'm just pretty disappointed at. I've tried a lot of different materials, thinking the technique and the material were my problem. And I call failure for anteriors and posteriors. If I need to treat the tooth again, it's a baby tooth. If I have to treat it more than once, I've failed. There's something wrong. Could be current decay, could be the film, newly decayed surfaces. There's a lot of reasons why fillings in baby teeth fail, and any need to retreat a tooth is a sad. I notice it every time. So I've tried compressible, flowable, comprimer, glass ionomer, and opening contacts, even kind of slowly going towards doing less dentistry on anteriors. None of those really work, though. The disease, the fillings would come out, or they get new decayed surfaces. I don't do a lot of strip crowns because I don't use, I think you can do those with a kid who's not wiggly, but if you have anterior baby teeth, you're probably pretty young. It's hard for me at least, to do good strip crowns. So there's other limitations on the back teeth. When I first got to the clinic 10 years ago, straight out of school, I was going to figure it out, right? I looked through charts, thick charts of a 6-year-old with a thick dental chart. Did the anteriors when they were 3, and then we redid them, and then we did occlusals. That kind of worked, but then we did occlusals at maybe 4 different visits because they got 1 at a time, and then noted interproximals, and some of those fillings, by the time the older kids come in, have broken or coming out. It was just a nightmare. When you're treating kids who are going through a lot and they're not happy to see you, and the whole thing seemed like a big mess. So what I did, and I think to some extent this works for posteriors, is I got more and more anxious to put crowns on them because my crowns didn't fail. And I wanted to do it in a quadrant. So I think pediatric dentists, that GA model where you take out the front teeth and you put crowns on the back teeth, I was kind of slowly creeping towards that. It wasn't very rewarding either, but at least I didn't have to retreat that quadrant in a baby tooth life cycle. So I have good success with steel crowns for sure. But it's pretty aggressive, and it's not. If I could do something different, I would. So the other approaches to prevention that we've tried with very little or no success, is increasing frequency of fluoride varnish. I was tracking those numbers, saw them go up, success. But the reason why we could do so many fluoride varnishes is they kept coming back for restorative. So I could do a lot of them during all the fillings that I was doing. Chlorhexidine swabs and rinses, tried that. So I still try that sometimes. Iodine swabs, I don't know if any of you got hooked on that. There was a couple articles that said iodine would maybe work better than chlorhexidine, and so I tried that too. Didn't see, I didn't measure it statistically, but I didn't see it obviously making a difference. And then I went to doing Fuji triage under occlusal so I could do a whole mouth in one appointment. And that's basically where I was before. I stumbled onto silver nitrate. So how did I get to using it? The reason why I hadn't used it before is I hadn't heard of it really. What I had heard maybe 13 years ago in a lecture in dental school was that there was this magical silver compound that did work, but it was for third world countries, and if you did it, it would work, but you're not allowed to use it. And that was silver diamine fluoride. And at the time, the teacher who was lecturing was trying to get that approved through the FDA, or had plans for that. But the silver nitrate has been available, as Steve said, through Henry Schein. It's available easily. It's just the silver fluoride that you can't use. Silver nitrate is not. It doesn't have that limitation. So when I heard Steve's lecture back in August, sort of like you're hearing, I learned about it. It sounded too good to be true for sure. Like I was like, no, I have nothing to lose on some of these kids, but I didn't believe it would work. Nothing else that I've tried that I've been told was going to worked. So the first patients that I chose were young kids with aggressive front teeth problems, which I already knew I was going to fail at anyway. So like the linguals, the anteriors on the baby. It was very quickly obvious just by looking at the lesion that it was working. I want to say that I had no idea what Carrie's arrest was. I called Steve and was like, well, it turned cavity dark. Is that, what do you mean arrest? What is that? And so it took 10 patients before I realized how to check it, like that the margins are important, that the texture is different. And so as soon as I got confident enough with those black dots on the back of the anteriors, then I started using for other kids that I thought I had nothing else to lose on. And then gradually moved to just generally using it for occlusals, which are easy to access. You can see the change. You can trust it yourself. And then eventually used interproximal. Interproximal is trickier than occlusals, but and I'm looking for my own data to progress to be able to really convince me what the exact right way to use it is. But does it work? Yeah, it's an antibacterial liquid. If you get it to the bacteria, it will kill it. So I don't want to get too much into it before I give you data. So far in my data set, there's 181 kids. There's a lot more kids who have had the treatments, but so far 181 kids. Again, no negative outcomes. So the protocol that I use is first we do the exam, fluoride varnish, and counseling on diet, strong focus on diet. Then the first silver nitrate application is at the second visit with fluoride varnish. I'm scheduled to come back anytime after a week. Then on the third visit, I've got the second silver nitrate application on, and then at that visit, I can evaluate how successful was the first treatment. It's really that different. And sometimes it looks really good, and sometimes I'm happy to be putting that second treatment on. For the fourth visit, which is always necessary for interproximals, I put fluoride varnish and silver nitrate again. So it's a pretty straightforward protocol. This is me putting it on. This is a pretty simple little video. I have a microbrush in my hand with silver nitrate. I'm putting it on the tooth. Uh-oh, don't do that. Backward. Okay. So then I put the silver nitrate on, and then I'm scooping up the fluoride varnish, and I'm putting it on the tooth. With silver nitrate, it's like sealants, but better because it goes super duper fast. You just have to make sure that you don't get saliva contamination. I use mouth prop isolation. I do it just like sealants. The video that you saw from Steve was kind of, in my mind, well, you saw two videos. I wouldn't do it without cotton reel isolation, for sure, four-handed. And I always use a mouth prop. I'm a little paranoid, maybe because I don't have enough years of experience with it. But you don't need isolation. The reason why you need isolation is to keep saliva off the teeth. You don't need isolation because it's caustic or anything. Silver nitrate will stain, but if you get it on the lip or the gums or whatever, it's going to stain, but it's not like it's going to hurt anything. So the isolation is not a protective type thing. It's just similar to sealants. You're keeping the saliva off the tooth. My observations are that arrest appears to be equally successful for anteriors and for visible decay, like occlusal, buccal, or lingual on posterior teeth. The picture that you see there, the molar that's really dark, that's what it looks like when it's arrested. It's not subtle. You can see it visibly, and it stays like that. I don't have as much experience arresting interproximal decay, but the initial cases are promising. It's a little bit, you have to be a little bit brave to do interproximals because what you're looking for is the lack of progression of decay. And you could probably relate that a lot of 4-year-olds who have interproximal cavities, they come back a year later and it's huge. So you're monitoring something that should be typically growing fast, and you're checking that it stops. So you have to, it took me a little guts to be able to do that, but it's working so far. I want to track it for longer. Arrest seems to be independent of changes in oral hygiene and diet. Hallelujah, oh my gosh, it's not that I don't want to change people's behavior, I do for many reasons, but I needed something that did not rely on me just hoping that things would change radically in a family where the 2-year-old, the 7-year-old has cavity, the 5-year-old, the 3, it's like I put these kids through a lot, and the 2-year-old has cavities. What else can how else am I going to motivate people? And I actually would be open to the possibility that behavior change is not enough in some populations, that there may be some non-behavioral aspects to getting cavities. I'm not sure. But either way, the silver nitrate will work to arrest it, even if they're still drinking juice. So this is the thing that got me excited. So after arrest, you can put the white fillings on. I do that whenever parents want the front teeth to be treated. I give them an option. But if I take out that dark spot with a round bird, it's almost like slow-speed round bird, underneath it is like actual tooth, not like this mushy, how close to the pulp am I, let me just not go there. It's like dented, like hard, solid, it's mineralized, it feels like a tooth. And that's actually what convinced me, because of the time frame that I'm working on, I've only been doing it for a year or so, that's actually what convinced me the most, is that when I was taking out the silver nitrate stain scar, underneath it was a tooth that was not similar to what I had been seeing before. I say it's a win-win-win approach. So I'm very excited because for 10 years I've been, feeling like I'm failing at what I'm trying to do. After starting to use it, me and the clinic one clinic that has implemented it, we do tons less of the Fuji triage, operative fillings, and stainless steel crowns. The win-win-win for me is the kids and parents like it. If you consider your own kids, I don't know, maybe they have cavities so far. Anyway, my 5-year-old and 10-year-old so far, so pretty good. The grooves don't look that strong, to be honest. If you had a kid and you said, I can either, take them in and put a crown on or do a nice white filling, or I can put this micro brush liquid on it, it's going to turn it dark. The parent isn't thinking, no way, you can't possibly turn my kid's tooth dark. And they're thinking, holy cow, really? No, you don't have to do a filling? Yay. Just like you guys would think. So the win-win is the kids and parents is one group. The dentist, so much easier, right? I'm not making kids scream and cry and hate me and all that stuff. So the dentists like it. And as far as the third win, I think the clinic system likes it because it enables you to do faster, easier visits. My dentists can reach their targets faster, and they're happy about it. I had to hold them back from using it after they saw it, because I only had my Monday day. I was doing it, and they were like, they did actually sneak and started using it before I said it. But now they're hooked, way hooked. So here is out of the data set that I have put together, out of 181 kids, I was able to evaluate 121 of them at their initial, like 1 to 3 months later. That's 525 teeth and 710 surfaces. As far as folks that I've been able to track for 6 months, I started slow and then ramped up. So I don't have a ton of 6 months, but of the 31 kids, 135 teeth, 183 surfaces. So that's what the data comes from. The data, some more caveats, based on my clinical experience with my patients. I chose the lesions a little selectively in the beginning, so some of the easier to access, not as many interproximals as what I'm doing now. For the patients whose decay didn't appear initially arrested, it is a beautiful thing. Just do it again. You have them come back. It's not really a failure. It's when you need an additional treatment. It's a strength of this technique. And there weren't that many, except for my initial patients, where I had to have them come back more than I thought I would. Because I would. Anyway, it's a technique-sensitive thing. My initial patients, I wasn't quite doing it right. For the data on Carrie's arrest, I've done almost all of the initial diagnosis, treatments, and evaluations. So of those 31 kids who I saw after 6 months, complete arrest in 30 of the kids, 133 of the 135 teeth were arrested, and 181 of the 183 surfaces were arrested. The one kid that I had incomplete arrest on was, they had 3 interproximals based on 2 sets of x-rays, the first of which, because it was like a 4-year-old, was kind of iffy on that side. And when I took a new, nicer x-ray, it looked like it might be bigger, or it might be the same, depending on the x-ray is. But I felt like, it's data, I can't guess. If it kind of looks like it might be bigger, then you have to score it as a loss. So the one failure is somebody who I retreated already and expect that to work. So I don't know. I guess with these kind of numbers, I don't have to explain that one failure is bad. But even that, I don't know. Maybe I'm too proud and let it go. But after 6 months, it's very obvious that it's working. And like nothing, because iodine and fluoride did not arrest these cavities. I could say one more thing about getting new cavities. It's just that 3 of these patients did have new cavities. 2 of them we weren't able to get x-rays at their first visit. 6 months older, we were able to get x-rays, and so we saw interproximals. So I don't think they were new cavities. And one patient, another dentist saw one of my patients who I treated early and said that they wanted to treat 3 more occlusals that I thought were probably not really cavities. So I don't know. I don't know if it would be great if this not only treated cavities but prevented future cavities in other teeth. So far, I don't have enough data to figure it out, but it's something that I'm tracking. So this is after our dentist got excited, got a hold of it. The x-ray shows like my normal treatment would have been a crown, like for the tooth, the tooth on the bottom there. It would have been, okay, it's a big enough lesion. I'm not going to treat that tooth twice. I'm going straight to a crown. I'm pretty aggressive that way. Instead of doing that, on the bottom, we treated with silver nitrate instead of putting the crowns on. The data, the line is, it just tracked the number of stainless steel crowns we were doing a month. And, with a high-risk young population, we were doing a lot of crowns. And it just continued down. Obviously, if a kid comes in and needs a pulp and crown, I'm going to do a crown after a pulp for sure. But there's a lot of big teeth you can treat with silver nitrate without having to do crowns. Win-win-win. The main benefit, it's a tool that stops the disease. It kills the bacteria that are causing the acid attack. That's something like when we were in dental school, every one of us would have been like, I want to find a way to actually stop kids from getting cavities, or work on this as a medical approach. But I think when we all became surgeons, including me, I love working on teeth. Kind of lost that goal, but it reminded me, just putting this presentation together reminded me of, I did think that, whatever, a long time ago when I was a kid, that there should be some way to stop the bacteria from causing cavities. Additional pluses, way less in need for referral or sedation for GA, less in need to perform restorative work on young, wiggly kids. I know my dentists like that. It's a simple technique, and it enables the clinics to succeed by seeing more kids during shorter and earlier visits. I want to say, well, first off, I just wanted to picture that's silver nitrate on some anteriors. The front teeth were too bombed out to save by any means. And then you can do these composites on the front teeth if you want them to look white. It's a pretty easy fix. But cleaning it up, like making it all good, that's John and Hay. I'm the same as you guys, like a dentist working with kids. We're not really interested in doing extreme tracking and documentation for each patient. And I think if you're going to try this or do this, you need to take a systematic approach and get some admin support to make sure that you know if it's effective or not. And John and Peg they worked harder than I did at this. And made it possible for me to. I saw them, you guys have to try to make it look good and need all the help I can get, and they do. So thanks. Those are my kids. My boy did not get anterior decay. He just knocked the teeth out. It's but that saved me the trouble. He does love sugar. And I think Steve should come up and answer your questions.
Any questions? First question. Does
this slide have to be plaque-free?
Please stand up so that we can hear you.
Do you want him to come up?
Oh, there we go. Let her decide.
Does the site have to be plaque-free?
Yes. So this works by a free silver ion coming in contact with the pathogen, with the bacteria. So anything that blocks that, okay, and a thick layer of plaque is going to block that, saliva is going to block it. So a clean, dried lesion is important.
Moffett and Steve, thank you very much. A couple questions. First, a general observation. It sounds like you may have found a silver bullet here. Moffett, what's the intervals between your visits?
Yeah, I think my intervals are at least a week apart. So between the 3 treatments, at least a week apart. That's compressing it as far as I can. We work with similar population that may or may not come back. I'm trying to do everything I can to make it work, but that seems to work.
And then more a curiosity question in regards to medical field reasons. Is there anything that stopped me from just starting to do this?
You want to answer?
Obviously,
Is there
you're doing
anything
this, but from
to stop you?
Is it considered standard of care?
Well, okay. I think that I'm glad that you brought that up. I believe that this, again, speaking for myself, represents a higher standard of care because we're actually approaching the disease with a biological tool. There may be other dentists that disagree with that. So, can you start doing it? The product is available. The technique is simple. There is a lot of literature on our library to help guide you. I emphasize the technique sensitivity part because I don't want anyone to try it and fail. I would rather that you come visit me in Kaiser and let's talk about it and see it and get trained properly. Moffett did an amazing job of educating herself via the internet. I finally had to say, can I come see you? I was so nervous.
Well, you probably got tired of me calling you every week when I was at
But I'm amazed with how much success she's having. I don't know if I answered your question, but I tried.
Good enough, thanks.
Dr. Mariella, pediatric dentist. I just want to ask the people who are attending here, how many of you are not a dentist or on the administrative level here? Raise your hand. Okay. The reason I asked that is Steve and I, for the last 1.5 years, I'm on the East Coast. I have a private practice in a community health center in Ohio and West Virginia. Bottom line, I started doing the technique over the internet. That's how we got trained. 28 patients, 130 that I have treated, a couple of failures, mostly interproximals. Things that have gone into the denting did not work well for me. So being selective about the cases is very important. By the way, Steve does not know that I'm here. So, but he and I have exchanged emails at 1 in the midnight too. He does answer emails in midnight.
Me? Really? Apologize.
That's fine. Yeah, the time difference made a difference. So, the biggest problem in my private practice was I was doing 5 visits, 5 applications, and Steve and I talked about it. The biggest problem was follow-up. A lot of patients dropped out because by the 3rd and the 4th visit, I was not a traditional dentist or a traditional pediatric dentist for my parents. I was only putting some stuff that turns it into black. They wanted more composites, more white color fillings and things like that. But my general dentist, who was the owner of the practice, basically told the front desk staff, try not to put them back on the schedule because we are not getting paid. So what I'm coming back to is how are we going to get reimbursed for these 4 or 5 visits? Okay. Technique is good, ethical, what we are doing, everything is right. But practicality-wise, should I have billed them as limited exam every time they have come in? I don't know. Is that called churning in our FQSA?
The billing question is a big one. I can tell you the simple answer for me is I care about it, and I analyzed it for the clinic that had that drop in stainless steel crowns, and we have not lost any revenue by using it. You have to know your state medical aid laws inside and out. You have to use them accurately, and we do. Fluoride is usually the billable service. You can do it with sealants. You can do it. You can when you put glass ionomers like over the food traps, you can bill that. So that's the kind of thing that you have to do. But it's not billable as its own. But we haven't lost revenue. And the FQHC environment is a great environment to try to.
No, it's preventive, so it's going to cost less on a day-to-day basis, but not on a PPS. I really think the private practitioners should use it. I have done 3 presentations in 3 different straits, and Steve gave me the presentation, so we did it. That was the first thing that I did before. I have 17 practices who refer patients to me, and I had to teach them first, this is what I'm doing, and I still get private practitioners send cases like, you might have a different technique by a different dentist, so we're going to send you there, and they know what black lesions are. So, they're pretty good.
You're a pioneer, congratulations.
Thank you. Thanks for your effort. And for the comment you made about the silver bullet, he has his paper says silver nitrate is a silver bullet, but I have to say it's not a magic bullet, it's a silver bullet. We still have limitations on those things, but it's one more thing in our armamentarium. And I don't think you need a dentist for all these 5 applications. You don't need a dentist to do it. An assistant can do it. I think the parent can do it themselves.
Don't start that immediately.
This is really just a rewording of the same question, but slightly differently. My comfort zone and you're talking about piggybacking on other sorts of procedures, and I'm thinking of a very young child. I'm trying to arrest caries, either let them get older so they can do more, et cetera, et cetera. But my kind of comfort zone is that, okay, I can apply it at the exam. I'm allowed to do, let's say, a toothbrush prophy as a billable visit within California, and that on a 6-month interval. If I stagger 6 months exams and 6-month toothbrush prophys, I can see them on a 3-month. So my question more specifically is here's down to, if I was applying this on that kind of interval, do you think that would be workable model? I mean, is that not? Is that a model I can move forward?
So we don't know the perfect interval. The paper that I published in the CDA Journal describes a protocol of application and exam 2, 4, 8, and 12 weeks. When I did that, I got 100% results. I mean, there's no question it works. It's been published. Okay, is it the best? No. A lot of people say, I can't get the patients back 5 times, and they're doing it. Moffett has explained she tries to get them back 2 or 3 times at 1-week intervals, and she's getting the same kind of results I was getting. So perhaps the 5 applications isn't what is necessary. Certainly 1 or 2 to get started.
Thank you.
I find this really exciting, but my question might sound a little negative. So I want you to like excited. I just like to think about possible negative outcomes ahead of time. So you said if you got some on the gums, it would stain it. Do we know how long that staining lasts? And then do we know how much, let's say, how much of the silver could get into the bloodstream, knowing the body doesn't get rid of the metals that would help?
That's a very good question. I experimented on myself by rubbing silver nitrate on my own gums before I got started this. It was gray for about 3 or 4 days and gone. Yes, we've had a few cases where silver nitrate was touched on the skin of a child or gingiva, gone in through 3 to 5 days. The second question, which is systemic absorption. So there are some conditions, argyria being one of them, where someone's skin color changes when they're exposed to large amounts of silver ion. The chances of that happening when we're following this protocol is 0, because the amount of silver ion we're using is infinitesimally small. So the systemic consequences, in my opinion, are 0. We have quite a section on our electronic library on safety and toxicity, and we might pursue some of that literature.
Thank you. I had several questions, but she asked one of mine, so I'll just limit it to 2, if that's okay. What about the indication for pregnant women in their first trimester?
Sure. I have a consent form and would not feel ethically any problem with using it on pregnant women. I think that group is always a group that people think about with risk. I don't think there's any real risk. I haven't moved to that population yet. I'm going to move to homeless adults first. And wait for the body of people who are doing this to get really big. But if I saw an indication like a really deep cavity where I wanted to arrest it underneath the filling, on an individual basis, like I'm not saying I've been learning this in all the clinics, but on an individual patient basis, I think it would be a good thing to use. Yeah.
Okay, and this is just a variation of the questions that have been asked before. How much time after the application do you restore? Are you still allowing that 1 week, or are you allowing a little bit more time?
Steve and I have different protocols. You can, it's a tooth with a cavity. You can restore it at any point. If you want to have the dentin build up, the secondary dentin, the longer you wait, the better. In practical terms, it's just a judgment call on how the parents are feeling about it. I'd rather not restore these teeth in general, but if people are concerned about their kids' front teeth, I'll do it based on that concern fairly quickly.
I have several questions also, so bear with me. Have you guys looked at the strep mutans levels in the mouth overall?
So clearly, this approach to care is central to managing the biofilm and the microbiology of the mouth. And yes, do we have the answers yet? No. The technology exists to look at biofilm profile changes before and after treatment, and we're working with a number of research institutions to look at that. And it might bear on the question of the incidence of future cavities if the biofilm changes. So I'm very interested in that question. We don't have a lot of data on it yet.
Yeah, because I could see definite applications. You know, you have the mom in the corner with her whole mouth bombed out, and then you have this kid, and you already kind of know things aren't going to go well. I'm thinking about the application to the mothers also, not just pregnant moms.
I'm glad that you brought that up, and this is just in my practice, and in spite of the fact that adults aren't covered for dental care, I discovered when I had a whole family in the operatory, I could treat the whole family for pennies and manage the disease at that level and had much more success rather than treating a tooth or a person.
My only other question, are you applying it to both cavitated lesions and non-cavitated lesions?
So, non-cavitated lesions, the classic white spot lesion, I prefer to try and remineralize. And if you place silver nitrate on a white spot lesion, you're going to have a gray spot lesion. Okay, so my first attempt is to try and remineralize that from an aesthetic standpoint.
Well, I kind of figured that. I was wondering about posterior teeth, though, if something that wasn't an aesthetic concern, if the combo might be more effective.
In a way, it's like a caries detector. If you treat it, you will see where the actual cavitation is on grooves. So I would say it's evolving, but I especially in a mouth that has other cavitated lesions, I use it on something that looks like it's a cavity, even if it's not a hole.
And then the only, how are you identifying arrestive decay? Is it just by visual and tactile sensation, or is there some other way to do it?
So there's very little literature on this subject, although I do recommend Edwina Kidd's book, Caries, the Disease and Its Treatment, and the section on arrest. But the major markers, the definition of arrest is it doesn't progress, okay, period. So if the lesion is not progressing, we know it's arrested. Now, lesions that become arrested often have a color change, so becoming more dark is part of it. And there often is a surface texture change. So it goes from a soupy, soft surface to a glassy or hard surface. Now, I've had some of my associates challenge that by plunging. It's sticky, I can stick it in there, and you know. So it's definitely a gray area, and we're learning. I wish I had a little tool that I could aim at a laser pointer and say it's arrested, but we're still learning.
Okay, thank you.
So both of you treat a lot of children. I'm excited about this maybe to use, I have a significant geriatric population, and I'm seeing with polypharmia a significant rise in root caries, which I have been often treating with silver, not silver nitrate, but the universal 150 and 151. So I'd like to get away from that. Do you have some experience on root caries in the geriatric population?
Absolutely. That is my second population of greatest interest, and health outreach goes to senior centers, and we are providing prevention care and treating caries with silver nitrate. And we're seeing the same rate of success, upper 90%, maybe even higher, in arresting root caries. And believe me, this population does not care if they have some gingival recession that now has a dark line, and they don't need crown lengthening and a crown and a root canal. Okay, it's just a miracle for that population.
Could you expand, you did mention the word consent form, could you just expand on that when you feel like it's necessary, not necessary, just your general experience?
I think it's always necessary. We have an example of the consent form that we use on the library. A standard PARQ, do we have a description? Does the patient make an informed decision, in my view? Okay, which means I've explained what the problem is, what the alternatives of care are, including silver nitrate, which I didn't know about before, the pros and cons of this approach versus another approach so the patient can make an informed choice. We use a written consent because this is something new. Okay, it is something new, and we want to have the patients just re-emphasize in their mind that we can make it. So there is a consent form. Everyone that I've taught this to, I've advocated that they use a consent form.
Have you used a diacronate to and see the difference?
Now you're pushing my buttons here. about that tool. Yes, I have no publishable data yet, but I found it very interesting to use the diagnodent to try to judge the size of a lesion. What happens when you arrest it? Well, we've actually tracked lesions after arrest and seen diagnodent readings go down. That's a study that I really want to be involved with someday, because if we could use the diagnodent as a metric to confirm arrest, we all feel more comfortable. It's a wonderful idea. The study has not been done yet.
Were you able to use your position as a Medicaid consultant in Oregon with Oregon Health Plan to introduce this as a possible cost-saving method? And are you aware of any other managed care large organizations like maybe Kaiser who would fund studies? Because this could be a huge cost-saving mechanism for them.
This is a cost savings. There's no question about that. And in Oregon, we have multiple dental care organizations that compete in the Medicaid market. One of those organizations embraced this protocol, taught it, and saw a decrease in hospital cases. Other competitive plans have kind of criticized that for market reasons. So there will be give and take. I think in the long run, either this works or it doesn't. You know, Moffett and I both said, look, 98%. Nothing in dentistry can claim that. Nothing. Okay? If we can do it, you can do it. And if it's true, then these little debates are just going to be irrelevant.
Some of the lesions that you showed on the pictures were pretty sizable. Do you use a particular criteria for when you might use silver nitrate versus we need to do this now? Restore now?
Well, I think we both should answer that. So in the paper that was published in the CDA journal, I try to speak to that very specifically. So silver nitrate is very caustic, and it could cause pulpitis if it got into the pulp. No question about that. So my recommendation is that there needs to be 1 millimeter of healthy dentin between the lesion and the pulp if you choose to use it. So if you're not sure, or if the tooth is showing some signs of pulpitis, I recommend some other approach to care. But I've been amazed how close to the pulp we're able to get.
Sure. If your kid is so young you don't have x-rays, it's a tough call, but what you can do is use the first appointment to start arresting the cavities and then plan to do the pulp and crown later. Once you, okay, this isn't, I'm not recommending you do all this stuff, but this is what happened to me, is that when I did those pulps afterwards, I got a better feel for, did I have enough dentin to arrest it when I took out the silver nitrate. So I would if you do start using it, use it cautiously with a millimeter of dentin, and then learn your way into how far the judgment call is, when to do pulp and crown and when to just try to arrest it.
I just want to say thank you very much for the great presentation, and very excited to actually try it on our kids. So I have a couple of questions. One of them is, in restoring the teeth, you mentioned about removing the stain. Do you have to remove the stain, or can you just put, like, let's say, a glass on top of that?
I think I gave two examples. One was an anterior tooth where we actually removed the arrested sort of dark eschar and then placed a cosmetic restoration without anesthetic, by the way. And then I showed examples of large posterior cavitations where we actually bonded glass ionomer cement right on top of the arrested surface. I'd like to give credit for that technique to Jeff Knight from Adelaide, Australia, who told me about it. And he published a paper that showed that the tooth surface that's been treated with silver compound does not inhibit the GIC bond strength. So I've done both depending on whether it's in an aesthetic zone or not.
Also, another question, in applying it for interproximal lesions, how do you apply the silver nitrate?
Yeah, I've been waiting for that one. And both Moffett and I will agree that's the most challenging case. And it still comes down to the same thing. If we're going to kill the bacteria, we've got to get this free silver ion in contact with the bacteria, okay? If you have an interproximal lesion, how do you get the silver ion in there? So the technique that I developed over time was to open the contact. I use a stimulant to open the contact, carefully dry, place the microbrush with silver nitrate in the embrasure. It wicks in. Okay. In some cases where the lesion is pretty substantial and I'm concerned that I will actually get silver ion in there, and I did have some experience with failures that I looked at, okay. On some cases like that, we'll just take a half-round burr and pop through an occlusal pit into the lesion and put the microbrush directly into it. So, and then just put a GIC on top of that.
Thank you.
Yeah, thanks for the great presentation. I went to the same school as Moffett, and I heard the same presentation and thought the same thing. And then a few years later in a residency, I had a kid come in and had black teeth, and mom said he had cavities, and they put some silver stuff on, and I think in Europe. And I was amazed, but I thought the same thing. This wasn't available to us, but I'm glad that I came to this presentation. You showed some pretty, like I was mentioned before, some pretty deep caries, and you mentioned removing food debris. How far does the penetration go? I mean, do you feel like you ever have to remove caries if it's a deep cavity to make sure you penetrate all the soft dentin?
Prior to application of silver nitrate?
Yeah.
So they're actually, in the silver diamine fluoride literature, this debate has been carried out, and I don't know whether there's a direct application, but the argument, do you need to remove some of that decay before you place the silver nitrate? Well, the ultimate goal is to get the silver nitrate in contact with the bacteria. So if you have a substantial lesion, okay, and you put silver nitrate on the surface and you don't think you have enough time for it to penetrate, then I would recommend removing some of that surface decay with a spoon excavator or something so that you are more likely to get penetration. Now, originally I decided to do multiple applications to ensure full penetration. And there is no data that tells you exactly. I mean, you have to use common sense to get to the endpoint that works for you.
I just want to say that I haven't removed dentin in deep lesions. So maybe as we get more people doing a more refined technique, there'll be some indications for it. But my thinking on it is that the silver binds to the protein that's there and it stays there. So it's like a source of antibiotic, even if underneath there I haven't gotten all the way down. And I do agree, like putting a significant enough amount of the liquid and sealing it in with fluoride varnish. The point of it is to try to really penetrate it. But just on a practical level, I haven't done that yet, and I hope that I don't have to. I would let that be the...
And you've had some pretty deep lesions and you've done it on with success? Okay.
Yeah, success.
And then on those larger lesions, like you showed us some pretty big ones, how many of those do you go back and restore just because, not necessarily to caries, but because of tooth structure missing? I mean, how often do you find you need to do that? Is this just a measure to keep it from progressing until you can do that, or do you actually just let it go and most of the time the teeth's stable until it exfoliates?
I think the goal is for the tooth to be stable until exfoliation on primary teeth, and if we have a food trap, it is so easy to put a GIC restoration bonded right to the surface. So I think it's individual needs-based decision. I saw the number of restorations I was placing dramatically fall. It wasn't an intended outcome. It was something that was discovered. I think Moffett has seen the same thing. And so it depends on the situation. I started this process thinking that I was just arresting decay so that then I could buy time to fill all those teeth. And probably for a year, that's what I did. Came back and filled and filled and filled and filled, and I found so much healthy secondary dentin and totally arrested decay. And then I met Jeff Knight, who said, "Why are you doing that?" And I had a change of thinking. Do it far less now.
Thank you very much. Okay, one question. 25% versus 50%.
Oh, excellent question. Okay, the Henry Schein, actually Gordon Laboratories in Philadelphia manufactures 3 strengths. Okay, 10%, 25%, and 50%. I started with 10%, and I think that that's why I had some failures. And so with caution, and as I educated myself about possible toxicity, I moved up to 25%. When I talked with Moffett, I was changing my mind in my own clinic to go to 50%, and I can tell you right now that we use 50%, and I believe Moffett is using 50%.
Just switched over. So I think it's well beyond time. No hard feelings if you want to leave the room. And I think we'll take this last question, and we can be available if you want to talk to us afterwards.
To what degree do you feel comfortable delegating the protocol to auxiliaries in your offices?
Let me answer first. You have more experience with this. My simple answer is I'm paranoid, and I don't. Not yet.
Yeah, I think that's well said. When something is new, we want to learn everything we possibly can about it before we delegate it or teach it. And that was certainly true for me. When I was trying to train an entire organization in Oregon, Advantage Dental, with multiple applications, I went to the Board of Dentistry, I went to the Oregon Dental Association, I asked, how do you feel about delegation for hygienists and assistants? How does the Practice Act look about this? And I did this 5 years ago. And so there was a period of time where I was training this organization that the dentist does the diagnosis, the dentist does the first application, there can be delegation of the second, third application, and then the dentist diagnoses the arrest. Well, there became some political controversy, probably for economic reasons in Oregon, and about 1 year ago, the Board of Dentistry in Oregon made the decision that a dental hygienist is not allowed to place silver nitrate. So we're in this very awkward situation in that one state where only a dentist can place silver nitrate. This is probably going to, it's silliness in my view, and it'll probably be addressed state by state.
I do think that speaks to a relevant point of we're on the cutting edge. We are safety net providers. We're going to do what's right for our patient, but you have to do it smart. Don't let the silver nitrate get a reputation as something bad that's for poor kids that turns their teeth dark. We are in a political environment, and I'm very sensitive to that. So I think it's a little bit risky even to give this talk, but I do it because it's the right thing, and I want you to be sensitive to the fact that it's a political issue also.
Please remember to fill out your evaluations for this program. I want to thank you so much.